Okay, welcome. So good to see everybody, and welcome to the new folks tonight, and welcome to everybody who's watching on YouTube. I'm Becky Berman. I am the moderator of this discussion with our host, Glenn Grossman. Glenn Grossman, as we know, is an epidemiologist with over 20 years of experience. While pursuing his doctorate in epidemiology at UNC Chapel Hill, Glenn served as an epidemiologist on staff at the UNC Infectious Disease Clinic for 2 years and taught epidemiology and advanced analytics at Duke Medical School and at UNC. He has been involved in epidemiology projects with Medicare, Medicaid, Veterans Health Administration, Military Health Service, the CDC, and other programs in the United States and abroad. He is currently Senior Director of Outcomes Research and Epidemiology at Novartis, but all views expressed today are his own. So what we typically do, everybody, is if you have questions along the way, you can send them to me in the private chat and I will get them in the queue. Thank you to everybody who sent in questions during the week. We have a lot of really interesting information, as always, to cover. And Glenn, kick it off. Then we usually start where you kind of take us through how are things here in the US and abroad and what's changed since last week.
Great. Yeah. Hi, everybody. So give me 1 second. There were a couple websites I did not open. And I'm doing that right now. Okay. So first I will start with this. Sharing my screen would be helpful. All right, so first, you'll notice when you look at the dashboard that for the first time in weeks, there are less red states now. The only red states on this dashboard are Florida and Georgia. And so a lot of states have now moved from red to orange. The primary reason is that so the caseloads have started going down. There's still a lot of, this is reported cases, there's still a lot of uncertainty in terms of the actual infections because in most of the states or many of the states that were red, the testing has gone down dramatically. And so it's not clear if it's just a reporting issue or if it's truly going down. Similarly, we'll get into this a little later, I hope, if there's time, talking about the hospitalization rate, how good is the data? And in fact, Becky, if that question was not previously asked, can you make sure that we add it about the data quality issues in terms of testing, hospitalization, all that kind of stuff? And so it's still a big question. And then we also have questions about the deaths themselves in terms of what percentage are reported as being COVID versus people who die from heart attacks and strokes that were caused by the COVID but not diagnosed with COVID. All right, so but at least this is good. The dashboard is going in the right direction. I like to see that, there could be some validity there. Again, not totally clear, but there could be some validity. Testing has gone down a lot across the country, but test and trace has improved. So now you see dark blue in the Northeast, and you see increasing blue in some parts of the country. And so, for instance, in New York State, there are almost 15 tracers for every single person that tests positive when a test is received. And New York and much of the Northeast is continuing to increase the number of tests, while a lot of the red states are decreasing the tests. And by red, I mean the color red here in terms of this dashboard. And like New Jersey is an example, not doing quite as well as New York. In New Jersey, there's almost 3 contact tracers for every positive test result. And it should be ideally closer to 15 with a minimum threshold of around 5. But 3 is still able to keep the numbers somewhat low. When you look at some other examples, like so Florida, which on the other dashboard we saw wasn't good, they have less than one contact tracer per positive test. And so it takes, so 0.4, so let's say it's almost, for every 2 positive tests, 1 person has to work full time on reaching out to every possible person who came into contact with either of those positive test results in the past 2 days and dealing with all the logistics. And it's just insufficient to address that. And so any state that's below 5 really has a hard time. Yes. Was there a question? Nope.
I don't think so.
All right, and so the other thing that we're looking at is the positive test rate. And so if the positive test rate, there's different thresholds in terms of what's good enough. I think the federal government might be saying that 10%, if it's under 10%, then that's good. Most of epidemiologists are saying that we should really try to aim for it to be under 5% positive test rate among all the tests, because if it's more than that, it means you're just not testing enough. And so right now in New Jersey, for instance, there's a 1.4% positive test rate, which is great. And so this dashboard itself is using 3 as a 3% as a target. The lower the better, because it shows that you're just screening widely and then getting a lot of negative test results because you're screening so many people. Whereas if you're getting a lot of positive test results, then that means that not enough people are being screened, because the ones that are choosing to get the test are the ones that probably have symptoms or think that they may have been exposed, and they're self-selecting. Whereas to get the numbers down below 3%, the only way you can get those numbers that low is if you're truly screening a much larger percentage of the population. And so people are really negative. So yeah, we can still see that these states in the South and the West are not out of the woods yet. They don't have contact tracing and testing sufficiently up to speed. And that means that a lot of them still have restrictions on their movement. And so because the numbers have gotten so high, when they start to open up again, because the contact tracing is insufficient, that means that the numbers are going to go back up again, because there's nothing keeping it from going back up. Let me stop sharing for a second and go over here. All right, and start again. All right, when we look at the big picture, there were 365,000 new diagnosed US COVID-19 cases in the last week. This is less than 374,000 we had last week and 437,000 the week before. So we are going down in terms of the number of diagnosed new cases, reported cases in the last week. However, our best, I think I like this website I sometimes refer to, COVID-19 projections. This uses machine learning, artificial intelligence, to estimate what the most likely infection rate is. And this estimate, which I think is among the best that we're seeing right now, estimates that there are around 341,000 new infections every single day in the United States. So all we're doing is reporting 365,000 over the last week, and yet the daily number of infections is likely to be far, far higher than what you would estimate from this weekly number. So, so these people are all contracting it, and a lot of them are spreading it on, and so that's problematic. When you look at another thing that people like to look at, so this is the daily new infections. A lot of times, a lot of people are saying, well, how many people have been infected in total so far? And our best estimate is between 13% and around 17% of the US population has been infected. The problem is we're not anywhere near herd immunity, most likely, which we still expect is probably going to be above 50%, maybe far above it, but there's still some uncertainty there. Could be 45%, could be a little bit higher, but somewhere around there is likely to be. In which case, again, we're nowhere near that number. And so it's problematic. When you look at this slide, so this is the number of tests, you see that the tests went down a fair amount, and that the daily cases also went down a fair amount. Now the tests have started to go back up again, and the cases have now flattened out a little bit. And so this I would say is probably a testing issue, that we're getting more positive test results, which is good because we're finding more people and helping to prevent the spread rather than truly dropping at something that's actually going on with the cases that we're flattening. Current hospitalized, that reported data has been going down. Again, still uncertainty with the data quality in all of these segments, but the daily deaths also were going up for a while and now have leveled off. And for a while, we were wondering, would the death rate go back up to the same level that we had earlier in the year when the outbreaks first started in the US. And the peak is far lower than we had back then. Again, the one thing to remember is that there are a lot of infections that occurred over the last few months, but there were a bunch of changes that have happened. The biggest ones I would think are the three biggest changes I would think are these. One, we have better treatments among people who are hospitalized. Two, and so if you go back here to the hospitalized rate, you see that the hospitalization rate actually was very similar in terms of their peaks now versus back in April. And so among those hospitalized, there's some new evidence that the treatments are working. We have better treatments, and so they're working some. The second thing is that among those who are exposed, we tend to be spending quite a lot more time outside, and a lot more people are wearing masks now. And between the two of those, and also physically distancing, between those three things, even among people who are exposed, we're tending to have lower doses at the time of exposure. It's called this inoculation dose. And that makes a big difference in terms of the severity of the disease. What we found, what we know with infections in general, and with COVID-19 in particular, is that the lower the dose of the infection, the less severe the disease generally. And so that means that wearing a mask, even if so we know that wearing a mask does prevent infection, but even if someone is infected while wearing a mask, it actually reduces their risk of dying and reduces the severity of the disease because it lowers the inoculation dose. So it's another reason why people should be wearing masks. And so I said two reasons. One reason was outdoors and the protection with the masks and everything. Two is the treatment in the hospital. And then three is, let me get some coffee while I remember what the third was. And then the third is, I would say the mask thing. The third thing I said was the mask. That in addition to preventing exposure, it reduces the severity of the disease. And so it's all of these things. So if all of these three things that protect us reduce the severity and so reduce the likelihood of death. Oh, and then also we also had this issue of younger people were the ones that were largely getting infected. There's still a lot of older people getting infected, but as you'll see a little later today, the averages were still that there were more younger people being infected. And so those three things, we know the infection fatality rate is vastly reduced for all three of those things. The age of infection, and the other two things that I said. So that's good. In terms of some of the other things that we're looking at, so this was the United States. If we look at, let me look at some of these other, so this is the first dashboard we looked at. This one is still dark red. This is a little bit more pessimistic, but the difference between this dashboard, this is the, let's see, this is COVID exit strategy. The difference between this one and the first one that we saw, which is COVID Act Now, is they use different criteria for coloring. This one is interesting because this is COVID exit strategy. The criteria used here are the ones recommended by the US federal government directly, where the US federal government at the start of the epidemic proposed specific criteria in terms of how is the disease spreading, can the hospitals handle the load, and how much testing is being done. And when you use just these three criteria, there's still a lot of worry. because what this means is that even if the caseload might be lower or going down, they're not prepared, and it could go back up again as soon as they reopen, because contact tracing and testing are not sufficient, whatever. And that makes a meaningful, it's a material problem here. All right, I'm going to go now to countries abroad. So there's a lot of countries in green here. Again, it's summer in the Northern Hemisphere, so it's much easier in the Northern Hemisphere for countries to get this thing under control now, or it should be easier in general. Things are only going to get more difficult in the winter when the North goes into the winter time. And as we can see, I'll go through these first, and then we'll look at some countries in the Southern Hemisphere where it's currently winter. But you'll see that a lot of countries have gotten under control. They're still struggling a little bit. Germany, you see a little bit of an increase. Parts of Europe, you see too. Not anything like it was earlier in the year when we first had the outbreaks. But you see that there still is a little bit of struggle in some of these. In contrast, when you look at South America or the Southern Hemisphere, so Argentina, it's continuing. It's wintertime. They were doing not so bad in the beginning. It was summertime there, and so it was easier for them to get a handle on it. But now it's just continuing to go up. Australia is the Southern Hemisphere. They've been struggling. They had an early outbreak when it was their winter. Then they got it under control. Now it's rather when it was our winter, when it was their summer and beginning to be fall. Now it's winter time in Australia, and the numbers have been going up. They are getting it a little bit more under control, but they have had lockdowns and stuff there. So they're being aggressive. When we look at like Brazil has been struggling. Part of this is a reporting issue, but they're just continuing to keep going up, 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 up. They think that they're doing well, and then they go down a little bit, and then it just shoots right back up, and then they think they're starting to go down, and it comes back up again. So I mean, it looks like maybe this is a peak, but again, they've had a couple peaks before, and then it just shot up. So it's unclear what's going on, but what we know generally, when you take a big step back, it's still been going up quite fast. Chile has had some reporting issues. It looks like they've reached a peak and come back down. They've had a very aggressive approach to getting it under control. So I think that this might be true, but again, the data is hard to interpret from there. So, but this would give me optimism. When you look at Colombia, again going quite high. So in general, you can see that there's a trend that the Southern Hemisphere is really struggling right now. When we look at Peru was, they also had some data issues. It's almost like a scribbly line, but yeah, they're continuing to go up now. Yeah, and so it's a challenge. Sweden, sometimes people have been wondering about. I mean, Sweden, we've talked about them a lot. The US, so here's where we are. The US, we never got down back under control like much of Europe did. And so we went up. Now we're going down a little bit. Again, this might be because of testing that we'll explore a little bit later. And now it's sort of flattening up, possibly going up a little bit. The one thing I wanted to just show before we look at other things. So this is not what I wanted to show. This is what we could show. Yeah, so Chile makes this hard to interpret. I'm going to remove Chile. So when you compare the European Union to the United States, we're both in the Northern Hemisphere, and so it is summertime for us. And so there is no reason why the United States should have our outbreak so high compared to the European Union. We're a wealthy economy. This was all management. At the beginning, there wasn't much any of us could do. But Europe got theirs under control much quicker and got it down much quicker. When you start getting to this point, you can see the deviation where the United States just kept on going up. We never got it down under control. And then when we started opening everything up again, as we expected, it all just started going back up. There are constraints now in a lot of the states that were heavily hit, heavy constraints in terms of what things are opened and whatnot. And so the numbers are still quite high. However, what I wanted to show here was the comparison with the Southern Hemisphere, where it's wintertime. And you can see Brazil, Peru, Chile was also high, but I took it off because they had data reporting issues earlier on that just made it so you couldn't clearly see the data here. But you see Brazil and Peru still have very high daily doses, so it's burning through their populations right now. Not under control. The fear is that this will be what our country looks like in the winter. And it's because Europe is not doing extremely well right now. But they're going to be better off come winter because it's going to be, the less cases there are, the easier it is to get under control. Our caseload is so high that if you look, let me get rid of Peru and Brazil. So when we started over here, because our caseload was so high, this was the new floor for us. So when we opened back up, it all went higher from there. As we approach winter, this will be the new floor. If we don't get this down, when we hit winter, this will be the new floor, and then we're just going to go back up again, even higher. And so this is what a lot of us are worrying about for the winter. So hopefully we can get it down a lot further in the next few months, but it's going to be troublesome. We know why does it spread so much more in the winter? There are 2 or 3 big reasons. One, people spend a lot more time indoors in the winter, and it's much easier to get infected indoors. 2, it's harder to keep physical distancing up and all of these things. And 3, it overlaps with the flu. And when you have coincident flu, then in addition, and colds, then there's additional symptoms that come up. Because then in addition to it being just a coughing disease or spread through breath, then you have sneezes and other things, and you can get spread much further across the room. And so it's problematic. We do know that the effective this reproductive value goes up quite a lot in the winter versus the summer. And so that means that the numbers are going to go up. Additionally, with schools reopening, schools are breeding grounds. We know that flu spreads through the schools, and so people have a much higher chance of getting spread when the 2 things overlap. Yeah, and so this is where we are. Are there any questions about where we are so far? I've talked quite a lot. Nope.
Any questions? So glad to see we're seeing some good news on the home front, although
Agreed.
not as great as we would have hoped for. But, he spoke about testing, and testing levels went down and went up. And now it sounds like we have different kinds of tests. And I almost said, can you dig in a little deeper? But then I was thinking, no, I don't want to say that, because the test right now is, from what I understand, is quite intrusive. So what do you know about the saliva test, and how ubiquitous is that? Can we get that? Can we do that at home? Will we be able to? What are your thoughts?
Okay, yes. So you are talking about, You are talking about this. So there was an existing saliva test, at least one. I remember reading about the one from Rutgers that was developed a couple months ago. This new one was developed by Yale. And what's interesting about this one, it's called Saliva Direct. And what's interesting about this one, so it just received emergency use authorization from the FDA. And now I'll tell you what's most interesting about this one is that they use commonly available materials to make for the reagents that are used for the test for the labs to use. And so basically they looked at the most common reagents that are being used for all the other tests out there, and then they use those for their test. And so because these reagents are already being used, they tested this in a lot of different kinds of reagents. So if the supply chain fails for some kind of reagents, then it could also work for other kinds of reagents that they bring in that are more widely available at any point. And the reagents that they require are much less expensive than the other tests. So we're expecting that that per sample, the labs might only charge around $10 per sample. It might only cost a couple of dollars for all the reagents and to put everything together. And so this is a lot less expensive than the other ones, which is great. It's quick. It should be able to produce results in 3 hours or less. Accuracy is on par with the nasal swabbing and other tests that are being used. And yeah, so and it's a recipe. So rather than being a kit that's being sold by anyone in particular, it's a recipe for any lab to use. So it's going to be much, much more widespread, much easier to do. And so any diagnostic lab in the United States or around the world can now use this, and it should make it easier for everyone, which is really great. And so yeah, that's good. Now, the one thing I want to tell you about going back for a second for the diagnostic tests is this. All right. All right. So so this we're looking the website we're looking at is the COVID tracking project. They did an interesting analysis a couple of weeks ago looking at the number of diagnostic tests, and what they found was that nationwide the number of tests had been going down a lot. But when you start digging into it, over here, there's a few states in particular that were really driving the decrease. So California was pretty level and was going up even a little bit more. New York was going up slightly, but so they're doing sufficient testing. Illinois was going up, but the two main states that are testing the most were going down, and that's Texas and Florida. Texas reduced its testing by 20% over this time period, and Florida reduced their testing by 31%. This is a huge failure. So if Florida reduced its testing by 31% and their caseload went down by 31%, I don't know exactly how much it was, but it went down quite a lot. How much of it is just because they're having less tests? I mean, so this is what Trump was saying for months. Oh, the only reason we have more cases is because we have more tests. It's actually not true, and there's a good. I mean, we saw that we've been increasing tests over time from the beginning. Like when you look at New York, their test rate was going up, 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 up. I mean, or flattening out, and yet New York, they had that early peak, then it went down, and they're still quite low. So the more tests they do, they're not seeing an increase. So it's silly. But if you don't test enough and the cases truly are there, then it perceives that there's less because there's less reporting of the cases. And so when you look at this, these are the two main ones. Texas and Florida have went down tremendously. And when you look at some other ones, North Carolina has gone down 12%. Minnesota has gone down 30%. Alabama has gone down 13%. Nevada, Missouri, they've gone down. And so as a result, it makes it really hard to interpret. How are we doing? Typically what you would do is then, okay, you'd say, well, if we can't trust the testing data, then maybe we could test the hospitalization data. And so then you can look at the hospitalization data. The problem is, if you recall, we had this issue with reporting. Let me make this a little bit bigger. We had this problem with the CDC was responsible for collecting all the hospitalization data. And then I think around a month ago is when the HHS, the Health and Human Services, decided to change how that works, took that responsibility away from CDC and gave it to a private company that no one really knows that much about. The House has tried, the U.S. House of Representatives has tried to get information from them, and they've refused to answer. And so it's a real challenge to know what the heck they're doing. And so it's problematic. What this website has done, and again, we're still looking at the COVID tracking project. What they've done is they found huge discrepancies between what's reported by Health and Human Services and what's reported by the state. And so some of these have a discrepancy of over 200%. Some of them, and it goes in both directions. Most of it is that Health and Human Services is actually saying that there's more than the states are. And we have no idea how to interpret it. When the state says there's a certain number of people hospitalized and the federal government through this private organization is saying a different number, there's no way for us to interpret this. It makes it really hard. And so that means you can't trust the testing data. Here, let me show this. You can't trust the testing data, and you can't really trust the hospitalization data. And so one of the most interesting thing that we really should be paying attention to here is, well, okay, we know that it varies by state, but does it vary over time? Like, so maybe if we were to adjust it based on the reporting of the states, we could maybe have a better idea over time if there's actually an increase or a decrease or what's going on. It's hard to tell. When you look at the different states, you see that some are changing, are going down over time. Some might be slightly increasing over time. There's no rhyme or reason to it. It's just random bumps. It's just hard to interpret. So right now, there's huge data quality issues that make having any idea what's going on really challenging. There's just a fog right now in terms of what we can really interpret. And then the final thing that we've talked about previously is the excess death rates. And even, so I'm looking at Texas here, the blue are accurately reported COVID-19 deaths. It might not be that the patients are accurate. There are false positive COVID patients, but at least in terms of the number that are reported, we know that that these are likely to be. But then we know that there's additional patients. Anyone over the orange line are additional patients that were not diagnosed with COVID, but were also excess deaths. And so they were a result of COVID in terms of, because we know through the epidemic and to epidemiologists, this is how we interpret it. Any death over the orange line is an excess death associated with the epidemic. And so these green are largely heart attack, strokes, other types of things. We know that COVID-19 promotes heart attack and stroke. And for some people, they might be asymptomatic and then die of a heart attack and stroke, or one or the other. And it was due to COVID, but they didn't know it because they had no symptoms. They had no idea they were infected. Maybe they were either not tested or the test came back a false negative or what, and it's a problem. Anyway, so I think that answers that question in terms of, I told you about the saliva test and I told you about the problem with all the data is hard to interpret right now, but testing in particular is concerning a lot of us, that the testing is going down dramatically. So we don't even know if the number of cases is going down or up or what. I personally think it's going down just because of the interventions that have taken place. And so I do believe it's real. I just don't know that it's going down in quite as fast a manner as is being reported currently.
Glenn, we have a question from Sandy. Sandy, I'll unmute you to ask.
I did.
Oh, you are good.
Okay, I'm unmuted. I'm just curious, are any reasons being given by the various states as to why there is less testing? I know we had some weather issues about a week ago or more in Florida. So I know that the testing places were closed, but I'm not sure about other states, and I'm not sure about why it's still going down. Thank you, Glenn.
Yeah, sure. So let me, there's a good, here. So I'm going to go back to this website. I'm looking at tests over here. Well, let me go to Florida because that was a good example. Or I guess it only allows me to do it regionally here. Let's look at the South. All right, so in terms of the reasons, no, that's not what I want. What I really want, oh yeah, here's. So in terms of the number of tests, the number of tests have been going up a lot. Like we're looking at 800,000 here. This is all, or not 80, sorry, 800,000. When we look at the South actually makes up a fairly big portion of that before it started going down. And so I think that what happened was that we were good at stockpiling the tests when there were less cases around and manufacturing and churning them out. But we've just hit a wall, I think, in terms of just our ability to get the tests. There are just insufficient tests available. And so I think that explains quite a lot of it. I don't know what else there is. I know that we're just insufficiently, if you recall, back in March and April, there were not enough tests out there. And so it was a major problem. We were all many of us had stay-at-home orders. And so because of that, because of the lockdown, it didn't matter about the test so much, because if we didn't feel well, we would just stay home. And then it was as if we were tested positive, so it didn't matter. But now, where a lot of states are more loose in how many people can walk around, it contributes to continuing spread. I don't know that there's any other reason there. I mean, we have heard Trump continuously say that the tests are driving the cases, and which is false. It's just simply not true. But I mean, there's no way for me to critically evaluate our states purposely manipulating testing and reporting of testing in order to make it seem like there's less cases. It could be the case. there's no way for me to understand. But except by going back to this chart that we just saw, where when you look at the states, it is weird that California, which is not a red state, is not going down. New York, which is not a red state, is not going down. Again, Illinois, not a red state, not going down, but yet the ones that are going down are these red states. Very weird. Again, I mean, it's a lot of red states here, so it's just hard for me to interpret. I mean, one explanation could be that the states are just insufficiently funding their response to COVID, and they just aren't purchasing enough tests, and that could be. States across the country are struggling in this economy, and states have a legal requirement that they must balance their budget. So if they need to spend more money, they need to either raise taxes. In a time like this, you can't easily raise taxes because the citizens themselves are struggling, or the federal government has to take out additional money and give it to the states. And so, because the federal budget can go into deficit spending and take out debt. And so the federal government has insufficiently been funding the states, and so the states are really struggling. So, I mean, that could be the easy explanation, that currently the South are the ones that are struggling the most, and they just don't have the budget that they need to respond to the outbreaks.
Very interesting. That's a really interesting interpretation. Let's hope we can get some more resources where they're needed very quickly. We have a follow-up question from Harry. Harry, I will unmute you regarding the saliva test. Okay.
Okay. Are we unmuted?
Yes,
Yeah,
you're unmuted.
so the question is, are we going to see the same false positive and false negative rates with the new saliva test that we saw with the conventional test, the nasal swabs?
Yeah, so there are, with every test, there's a false not positive and false negative rate. There's no way to avoid that. The accuracy that's reported is on par with the results from the current nasal swabbing. So we think it's going to be fairly accurate, and by that we mean it's going to catch the vast majority of people who truly have SARS-CoV-2. It's going to catch the vast majority of them and identify them. It's going to miss some people and who do have SARS-CoV-2 and tell them that they're negative when in fact they truly do have it. And so there'll be some leakage and some people will continue to spread. But at the high level, there's this debate among epidemiologists. Is it better to have a worse test, so it doesn't give as accurate results, but have it way more readily available so that it's given much more widely, so that we screen people, let's say on a weekly basis, even if we were to have it much more commonly available in the supermarkets and everywhere, where it was just everywhere? Would that be better if it's less accurate, or having a more accurate test that's given less frequently? And a lot of epidemiologists are on the side of saying it's better to have more tests more frequently, even if the accuracy is not quite as good at the population level. And so I agree with that assessment. I think that having more frequent testing is better at a population level. Something like a saliva test, I don't know how many of us on the call have had one of these nasal swab tests, but they are not comfortable to do, and it's a pain in the neck. And so with the saliva test that you just spit into something, it's just so much easier. I think people will be much more willing to get the test done. And so with accuracy that's on par, I think we're going to be in really good shape, especially if we're doing it so frequently that maybe once a week people are getting the test done. Just having so many frequent tests, even if there's false positives or false negatives, we're still going to pick up quite a lot more people.
Looks like Harry has a follow-up question.
So, just to clarify for people that may be watching that haven't been tested, the nasal swab feels funny.
Oops.
Oh, Beck, you muted him.
Sorry.
Wait a second. Okay, Dad, you were muted.
My fault. Sorry.
Wait, you just muted him again.
Okay, start over. That was my fault. So I apologize.
Just to clarify for everybody that's listening, having the nasal swab is not terribly uncomfortable. It's like a bug that went up your nose, but it's not terribly bad. So I wouldn't hesitate to have it done.
Oh, of course not. Everyone should be testing it. It's even though it's a little bit uncomfortable, everyone should be getting a test. If you've had it once, then that only tells you if you were exposed prior to that test. And so every day since you've had your last test, you could have been exposed, and you may be asymptomatic. So just because if you had a test a few weeks ago and you've been out and about going to the supermarket and going out, just because you had a negative test back then does not mean you are negative currently. So people should be getting tested frequently. But it is not the most comfortable thing in the world. Having a bug up my nose is not something I seek out normally. But this is it isn't it. People should be tested, and so I think this might help with people getting tested more.
Yeah, well, I have to say that this saliva test is being introduced just in the nick of time. My kid's school has announced that all students, teachers, everybody, administrators, everyone who works at the school, everyone needs to be tested before school opens. So I am hopeful that I can find a location that will offer this saliva test, because kids are really not necessarily running to raise their hand to have a bug up their nose.
So I'm curious, how once the kids go back to school, is there a requirement for continued testing? How often will the kids or faculty and staff be tested? And if they test positive, how much communication will go out with the class, with the school? Do you know that yet, or is it still being
We
determined?
know a lot of that. There's more to come, but the school just released like a 15-page document with detailed plans, and was really, really informative about, answering some of these questions, not all, but just really what's in place. And in fact, I drove by today, and it was great to see on one of the campuses, there are tents set up all over the different fields, and the kids are going to be eating lunch outside and, doing so much outside, and it's already set up 3 weeks in advance. So it's exciting to see that.
That makes an enormous difference.
Mm-hmm.
That makes an enormous difference, being outside versus inside. That one change alone, even if the kids are a little bit closer outside, hopefully they'll still be able to maintain their physical distance, but simply being outside makes an enormous difference. That's great.
Yeah, it was really good to see. So let's talk school. What's going on around the country? This is really top of mind to so many, not just parents, but to grandparents. So many people have been really socially distancing and isolating in many cases, and really being very careful all summer. And now here we are, we're talking about going back to school. So what are your thoughts? What are you seeing out there?
Yeah, so a couple interesting things going on here. Let me switch for 1 second. All right, so I am looking here for this. So it was just reported. So I don't know if we're going to see more of this, but so some school systems are simply not prepared to open up again. Your school system with the tents outside and a really systematic policy that they're creating seems like they're in a good place. And especially they're located in New Jersey, which has a very low caseload right now. And so they are really well positioned to open up. In much of the country, they are not well positioned to open up because there's all of these active outbreaks. The spread is too high. And so as a result, there's a lot of concern among faculty and staff at these schools for opening back up again. And what we've started to see are people having sick outs. So these faculty and staff at the different schools have decided, okay, when school opens, they're just not going to show up and just call out sick. And a school system can't open if people do that. So what we saw in Arizona is that an Arizona public school district just abandoned plans to open after 100 teachers and staff called in sick. Similarly, there are talk about it spreading around the country. And so in other counties, other school districts that have high caseloads, it would not surprise me if we start seeing more of these sick outs and then we don't, and they end up not opening. And for much of the country, it's probably, they should not be opening. That there's a current outbreak going on in much of the country. And so for instance, when we look here, let me pause for 1 second. So for instance, when we look here, So in much of the country that's dark orange or red, these are counties that have an active outbreak. These counties really should not be opening for school because there's an active outbreak going on. And so under those conditions, it doesn't make sense to open the school. It's just because the worry with opening is that you're going to cause a new outbreak. And guess what? This outbreak is uncontrolled. And so opening the schools is only going to make matters much, much worse. In contrast, much of the country, so for instance, the Northeast, where the number of new cases daily is quite low, then opening school is a serious choice that a lot of communities should be making. And so, but it varies. Like I say, there's a lot of this. It's not the same answer for everyone. If someone is in a red county, there is no way they should be opening just because it's an active outbreak that's out of control. People will be going to the hospital, and opening the schools will only exacerbate that. And so it's problematic.
What about schools, with schools about to reopen? There are many multi-generational families living together, or maybe not necessarily living together, but seeing each other on a very, very regular basis. What are your thoughts in that area? Meaning, schools opening, it doesn't just impact the children and the staff, it also impacts older relatives.
Yeah, and so that's a really interesting question. The Kaiser Foundation did a study on this recently. And so they asked the question, how many seniors live with school-age kids around the country? And what they found were that around 6%, almost 6.5% of all seniors in the United States live with school-age kids. That represents around 3.3 million people. Again, this was the Kaiser Foundation that did this work, and that they used the census data. When we look into this and dig a little bit closer, so it does vary tremendously by ethnicity. So American Blacks are almost 3 times as likely to have a senior live with a school-age child. And so that means that they're at much higher risk. And even higher than that are American Indians, Hispanics. I mean, look at the difference between this. And then Asians and Native Americans, or rather Native Hawaiians, Pacific Islanders. Tremendous number of cross-generational households, which was similar to Italy. That was one of the reasons that Italy got hit so hard so fast, was because they had a much older population. And in addition to having an older population, they had a lot of cross-generational households where the older people were living with the younger people. And so this could be problematic. When you look at this at the state level, and so you see that it varies dramatically by state. So in California, there's on average, what is it? Not quite 14%. I think this is like 12% of the kids, the school-age kids who live here. Oh no, I said it the other way. This is among seniors who live in California. Around 12% of them live with school-age kids, and that's a lot. This is material. New Jersey, I think, was closer to like 6% or so. The Northeast and New York around the same. And you see it varies dramatically, but there's some states. Hawaii, I think, is the one with the highest because of the Pacific Islander concentration and whatnot at 14%. But so opening up the schools, this is another reason why, in addition to the current outbreaks, simply what seniors live with school-age kids varies a lot by state. And it's going to be important, because even though we know the kids themselves are at extremely low risk for having serious illness as a result of this, we do know that a lot of them are going to bring it home. Our assumption right now is that kids who have not yet had puberty are less likely to spread it, but there still is spread, and we know, especially if kids start getting flu and other things, then they get it at the same time, then it could be troublesome.
Very interesting. Definitely another element for so many of us to keep in mind as we move into school opening stage. So we spoke about testing and we spoke about excess excess death, the chart that you showed us. Has there been an impact? A question came in. Has there been an impact of improved treatments on the fatality rate now versus back in April?
Yeah, there was a study that was just published. This is a really great question. And so we know originally that the best estimate of the infection fatality rate was around 0.65%. It did vary by state, it varied on a bunch of things, but on average, when you put all of the age groups together at the population level, we assumed that it was approximately 0.65%. But now we know that the treatments have changed over time. So first so let me make this bigger. All right, so this study looked at the difference. They had the first surge. This was a specific hospital in Texas, in Houston Methodist in Texas. And so their first surge was from March 13th to May 15th. And then they compared that to the second surge, which they said was from May 16th to July 7th. And so there are a couple interesting things that when you look at this. First, the percentage of people under age 50, we know that if you're under age 50, then it dramatically reduces your risk of severe disease and of death. So this makes a big difference. It changed a lot, and it went from around, among those hospitalized, 29% were under age, let's put it this way. Among those hospitalized in the first surge, around 27% were under age 50. And yet in the second surge, the one we're currently going through, 34% were under the age of 50. And so this was a big reduction. And so this alone might complicate our interpretation of why the infection fatality rate is going down, just because there's a lot of people under the age of 50 in the second surge. But let's still go through it, because there were some interesting things that we found. The other big difference that I wanted to point out here, there's some other things in terms of just other interesting tidbits there, but the one I want to bring your attention to is, so remdesivir, we know, is an effective treatment. It was used a little bit. It was used by 11% of the hospitalized patients in the first surge, and now more recently it was used by 22% in the second surge. So this was quite a lot more remdesivir that was used. It's like a doubling, going from 11% to 22%. Although there's technically a lot more patients in the second surge, so it's a lot more patients than double got it, but as a percentage, it was a doubling of the percentage. Convalescent plasma therapy remained around the same. Expirin is a anticoagulant that went up a little bit. Hydroxychloroquine, which we've talked about a lot, which we know is not a viable drug anymore. It had emergency use authorization at the beginning, but then it was revoked because the drug doesn't work sufficiently well. So more than half of patients were getting it originally, and now it's virtually none, 0.5%, so under 1% are getting it. And then there's other anticoagulants that were also used. Previously they were used more, and now they're being used a little bit less as a percentage. But the big ones, there was some worry about hydroxychloroquine, that in addition to it not working, that it might actually hurt, and might actually cause more severe disease and cause death. And so reducing it might have been an improvement in itself. But then over here, remdesivir, you see dramatic increase, and that makes a difference. And then also anticoagulant makes potentially a big difference as well. So what does this mean? So I'm sorry that these are so small. Let me make this larger. So what this means is that the length of hospital stay was reduced by 1/3. That's huge. So among all the patients in the first surge, 1/3 less as a percentage in the second surge, the average patient stayed 1/3 less in the hospital. That's a major improvement. The total deaths, and this is enormous, total deaths were reduced by 71%. Now, I did mention earlier that a lot of the patients were under the age of 50. And so that means that some of these deaths that were reduced were not because of the drug, but were rather just there were less people at higher risk. And so I don't know exactly. I didn't do the math to try to adjust it in terms of what that might be. But yeah. So total deaths were, but this is huge. Total deaths were reduced 71%. More interesting as a metric are the ICU deaths, because the ICU death age range and risk in terms of comorbidities and other factors was likely to be roughly the same in the first surge and the second surge. And so when you compare ICU deaths reduced 17%. And so this is probably, in terms of our best therapies, this is probably a good indicator, although we did find that we've reduced the risk of getting into an ICU by some of these treatments. So if you give remdesivir, you give other things that might reduce the risk of going into an ICU. And so that's good. But among people who are in an ICU, the risk of death did reduce 17%, and that is an important reduction. The other thing that was not included in this study, but that we saw when we looked at CDC's excess deaths, is that COVID-19 diagnosis might be worse now than it was then. And this is something that's still being investigated. But in terms of the false negative deaths, it could be that people are having heart attacks and strokes, and they wouldn't make it into a study like this because they were not diagnosed with COVID, but it was caused by COVID, the reason that they had the heart attack or stroke. And so the question is, has that increased as a percentage in the second surge versus the first? We don't know. When you look at Texas, do I have excess deaths? So when you look at Texas here, you see in what they're calling the first surge was down here where they didn't have a huge peak, but they did have some. It's hard to tell with the numbers that are here what the percentages that are false negatives that were excess deaths, but were COVID. Whereas it's clear now that quite a lot of the excess deaths due to COVID are not reported as COVID. They're the green ones. But we know that they're due to COVID because it's epidemic. It's been triggering the epidemic, these pluses that are coming in. So yeah, and so that makes it a little hard to interpret as well. But between that, I think that it's still great news that both of these things, the fact that total deaths reduced by 71% is enormous. That's great. The length of hospital stays reduction, that is great. The primary reason, I mean, obviously people don't want to stay in the hospital, but if you recall, one of the major worries about this disease, like what we saw in Italy and some other places, was that the hospitals filled up and they reached capacity. And then people that were going in who did not have COVID, there were no more beds available. And that's the big value of this, reducing the hospital stay, is that if you get people out of the hospital sooner, then you open up their bed and then you reduce that ceiling. You don't have to worry about that as much because over the course of a month, you can get far more people in because the hospital stay is much lower per person. So this is huge. This is the first study that I've seen looking at this. And so we'll see as more studies come out. But right now, this is really great news. 71% reduction in death. That's amazing news, even if it's a little bit higher than what you would expect based on the age. And then the ICU death reduction. This is purely due to better treatments at that point, the 17%. So that's huge. It's really exciting.
We'll take it. Keep bringing on that good news, Glenn. I feel like we have been talking about a lot of good news. And I love when I watch the news during the week and they share reports that you've already shared with us. For instance, the Duke report that you shared last week about showing us the different types of masks. And I was so excited as I'm watching it. I'm thinking, I already know that about the bandana. I already know that about the, what do you call the turtleneck? What's the one where you pull it up? So the gator.
Yeah.
Yeah. So we love that you share this information with us. And then we love hearing it on a national level. And we are already the experts. So thank you for that.
You're welcome.
So we are getting near the end of our time, and I'm wondering if maybe we can wrap up where you can, a question has come in about the 6-foot distancing rule, and where does that come from? And now that things in some areas are starting to look better, certainly not everywhere, do we still think that that's a safe distance?
Yeah, that's a really good question. So that original study was looking, I think it came out of China. I don't remember. I didn't pull it up. We've talked about it previously. But basically, it was looking at the size of the droplet from coughing and from these other things. And based on that study, they found that it looked at meters. If someone was 1 meter away, then it reduced the risk of getting infected by, getting infected by approximately 82%, and then it reduced it by half for each additional meter away. But this was all based on this idea of the droplet size. Now this assumed that there was no aerosolization. So an aerosol, as we talked about previously, is when the droplet gets to such a small volume that it behaves very much like dust in the air, and it could just float around and there's nothing stopping it. It could go far away. It could just stay in the air for quite a long time. When the volume is bigger, then it goes and it just drops very quick because of gravity. But when the volume is low, then it's low enough that just the fluid dynamics of the air are what's responsible for it. And so we didn't know if aerosols were a thing. That original 1 meter is around 3 feet, 2 meters is around 6 feet. That original 6-foot recommendation was based on that, the size that we assumed the size of the droplet. The problem now, so there was some evidence that there was aerosolization. The problem is now we have the smoking gun. And so there was a study done that was just recently published. Here's the article here. And what we found is that they put some boxes that captured the air, that took samples of the air, and they put them away from patients in hospitals. And so these hospital rooms had the great filtration systems. I think some of them had UV light to prevent it as a sanitation, but they had great filtration systems and everything. They had air circulation, and they put boxes at different distances away from the patient. And the key takeaway from this study was that when a box was placed, the furthest in the study that they even looked at was 16 feet away from the patient, when they sampled the air, they found SARS-CoV-2 circulating in it. And this is why we continue to say that when you're indoors, it's not the same as being outdoors, because indoors, once something aerosolizes, it could just go in the air and then just recirculate for a long time. You could leave the room, or the person with SARS-CoV-2 could leave the room, someone else could come back in, and the SARS-CoV-2 in the aerosol form is still circulating in the room. And this is the smoking gun now. We know now that it's true. We had circumstantial evidence that was compelling before, but there was not a smoking gun. Now we have the smoking gun. It is an aerosol. It's been actively found at up 16 feet away. And the only reason we don't know if it's further is because it wasn't tested further. But once it's at that level away, then it's in the air. It's like a dust particle. There's no reason why it wouldn't go further than that, or just, it behaves just like a dust particle. I'm thinking now we should have maybe put this not the last one that we discussed, because this is not as good news as the previous question you had, but it is what it is, and it's something we need to be aware of. And that's why when we have these questions about goggles, if you're wearing glasses protect you from splatter. Like if it's the 6-foot question in terms of something that's a splatter, then it protects from that. From an aerosol, the aerosol just goes all over, and you can get dust in your eye even when you're wearing glasses. And once it's an aerosol, it's the same issue here with the masks. The mask could protect some, but if some of you might have worn a mask and you might wear glasses, and your glasses might fog up when you're wearing when you're wearing glasses. What that means is that the mask isn't sealed well enough on your face. And if the virus is aerosolized, like we've proven here, then that means that gap where the glasses are fogging up, it's all could be aerosol that's coming out. And so a lot of people don't wear glasses but they still have that gap because the masks aren't being worn perfectly. And so masks are extremely effective. It does prevent the large droplets. It prevents some of the aerosols from coming out, but they are not perfect. And so that was one of the original concerns when epidemiologists back at the beginning of the first surge, pardon me, one of the concerns was that people would think that the masks were like a protective shield that makes us immune from SARS-CoV-2. And that's simply not the case. You can be wearing a mask and still get infected with an aerosol if it's not sealed correctly. And that is something that it's going to be hard to avoid because a lot of people don't wear these masks correctly. And so this is a thing. Like I said earlier, if you wear a mask, even if you are exposed to an aerosol or are exposed through droplet, it is likely to reduce the severity of the disease. And so likely to prevent death, so if you have a less severe disease. But it doesn't eliminate the risk. And so the risk is meaningful when you still have all this airflow that's not going through the filter of the mask, but is instead going around it and fogging up glasses and stuff.
Yeah, I understand what you mean, that maybe perhaps it's not the best news to end on when we've had so much good news, but I think I speak for everyone in the audience to say, when I say that feeling informed, and even if you're not telling me exactly what I want to hear, I feel better knowing what the truth is than sort of false positive. I guess, can I use that in this context?
Sure.
So to me, this is good news, because I remember the last time we spoke about this and you showed us this sort of anecdotal report. I think it was from a restaurant in China and the circulation of the air conditioning. Now this is a scientific study. So I'm appreciative of this, and I will keep this in mind as I do things differently, and going indoors versus staying outdoors.
Yeah.
So
One thing I was telling our parents were that if someone else enters the house, they were having someone come in and do some construction for them. If they come in, if one of them was an asymptomatic carrier and had SARS-CoV-2, they could have been releasing it in the air. Even if they were wearing a mask, if it didn't have a perfect seal, they could be releasing it in the air. And then even after they left, it would still be circulating in that air. If they were doing work in a bathroom and then they used the bathroom, or depending on how that air was flowing outside of the bathroom. I mean, you referenced that study in China. One of the most interesting insights from that study was that the air was pulled into the air conditioning system and then recirculated and hit other people coming out of the air conditioning system. And so being in front of an air conditioner when the air is being pulled in from the existing air inside might actually increase your risk, because we sometimes think, oh, the airflow helps, but we do need increased airflow, absolutely, but people should not be standing in front of an air conditioner that's just recirculating air and then potentially exposing them to the air that's in there. And so my parents who are seniors, I told them that, I would leave the house for at least a few hours, if not more, if someone's in there for an hour or so, just to try to give it some time to settle. And this, once it's an aerosol, it can stay there for quite some time.
that's great advice. I really hope that your parents listen to you.
I don't know that they do, but I hope so as well.
Okay, well, with that, is there anything that you think we should keep an eye on this week, or anything you plan to share, not to put you on the spot for next week, anything in particular that you think is sort of a hot topic?
Oh, I don't know any specific hot topics. I do plan to go camping in the next week. And so Sunday night, I'm not sure. I'll be following the news intermittently, but we'll see. I'm not sure yet. It's hard to predict the future for the next week in terms of what the news will be. But I'm sure whatever it is will be exciting.
This is true, but I do feel, thanks to you, that in many ways we do have a crystal ball, and I do feel so thankful and really so appreciative of the way that you really tear apart the data for us in ways that we can really understand and take with us in our daily actions. So with that, I wish everybody a wonderful week. Stay healthy, stay safe. Thank you, Glenn. We really appreciate everything you're doing for us.
Thank you. Thanks, everyone. See you next Sunday.
Bye-bye.
Bye.